get in the webinar. It's like I can't. It says it's going to start Zoom.
It started. Check again. Someone was just telling me that they were unable to get into the webinar, but I told them you just started it, so they should check again.
Yeah, they're probably in the waiting room. Well, I'd like to welcome everybody to the webinar. Let me just get this set here. Can you see me okay there too? Let's see.
Yes.
Okay. So I'd like to welcome everybody to the webinar. We're really excited to have Dr. Kenneth Nwosu join us here from NeoSpine in Kirkland, soon to be Bellevue, the location. His training is extensive. First of all, he's one of the few physicians I've ever met that has an MBA as well, which maybe you can talk about that later. But also, his background is from the University of Texas as an undergraduate and Cal State, where much like most of our audience, he found medicine through injury. And that's where you kind of, sounds like you got your passion for the study of medicine. Ended up at UCLA where you did a rotation down there and then did a fellowship at Harvard. So a couple of schools that everyone is very, very familiar with. And now you're performing minimally invasive spine surgery. And I'll let you take it from there, but we're really excited to have you there. And it's fun to meet a new group and a lot of exciting things happening with your team there.
Awesome. Hey, thanks, Ben, for having me. I appreciate it. And thanks to all the attendees for attending. I think this will be a good session. Yeah, I spoke with you about this earlier, Ben. You know, I want this to be as interactive as possible. So as I go through the talk, feel free to interrupt and ask me questions as we go along. So without further ado, today I'm going to be talking about endoscopic spine surgery. But, you know, to understand sort of endoscopic spine surgery, I think it's first important to understand, you know, the reasons why we do surgery, spine surgery on patients. So I'm going to start off talking a little bit about sort of those reasons, and then I'm going to talk about the evolution of spine surgery from sort of your big traditional maximally invasive approaches into the sort of least invasive procedures. And then I'll talk specifically about endoscopic spine surgery. So back and neck pain, as you all know, it is very common. Most of us will have it at some point in time. I went for a 3-mile jog this morning and I'm having a hard time sitting down because I have shooting pains going down my right leg. So knock on wood, hopefully I don't need anything. It's the leading cause of disability in the world and is a significant economic burden, over $100 billion a year. So what are the causes of low back pain? Multiple things, you know, and oftentimes, you know, I have a patient, you know, telling me like, oh, I have pain shooting down my lower extremity. How is it possible that this is coming from my back? Well, the back is very notorious for referred pain. And there are many, many organs and anatomical structures in the low back and neck that can exacerbate the pain that may be felt elsewhere. Causes could be non-mechanical disease processes, you know, issues with the kidney, issues with kidney stones, endometriosis can typically present as back pain, mechanical issues like lifting heavy objects, obviously trauma, you know, motor vehicle accidents and falls are oftentimes common culprits, poor sitting posture. Is a significant cause of back pain, especially with sort of the evolution of our lifestyle, our sedentary lifestyle. And you know, as many of you guys know, the worst position for your back is sitting relative to the 3 typical positions of standing, laying down, and sitting. And then to add on to that, frequent bending forward while sitting can further exacerbate back pain. But the most common reason why people have back pain is due to degenerative conditions of the spine. And oftentimes patients see me and they're like, doc, you know, why do I have this? You know, and I'm just like, well, you just have degeneration of your spine. And oftentimes they're bummed out and they're like, did I do this? And most of the time it is not of their doing. 60 to 70% of reasons people have low back or neck pain is due to a sort of due to a genetic predisposition. So oftentimes just explaining that to the patient sort of puts their mind at ease regarding whether, they did something to cause the back pain. So back pain can range from mild to severe. Severe neck and or back pain can be very debilitating. And something that's very, very important, to recognize, and something that I like to share with my patients, is that most of us will have neck or back pain at some point in our lives, and over 90% of the time, that pain will resolve on its own. All right. However, when it doesn't, and when it's persisting for beyond 6 to 12 weeks, then usually patients should seek care from their primary care doctor. And evaluation is usually the history and physical exam. For me, that's the most important thing. I go into the exam room with a patient, and I just ask them, how did this come about? And it's kind of interesting how you sort of ask them an open-ended question, how they just guide you in the right direction. So for me, the history is the most important aspect of my diagnosis. Then I perform a physical exam to corroborate what they're saying. And then imaging studies come into play, X-rays, MRIs, possible CT scans, sometimes bone scans, and then labs. Oftentimes, the cause of the back pain is missed when you don't consider the fact that, the back pain could be due to an infection or a malignancy, in which case getting a C-reactive protein or ESR lab will help you determine if the patient's sort of inflammatory markers are elevated or not. Differential diagnosis is vast. There's a myriad of things that can cause back pain, and all these sort of differential diagnosis in the back of my mind each time I'm seeing a patient. And as the patient talks, I'm just checking things out. The patient says, all right, I have a ton of back pain. I don't have any shooting pain going down into my legs. Automatically, radiculopathy has been ruled out. I start thinking about facet-mediated back pain. I start thinking about discogenic back pain. I start thinking about spondylolisthesis and things like that, okay? The patient's telling me that, I have pain that's at night, that wakes me up in the middle of the night. I've had a significant amount of weight loss, not deliberate weight loss. My appetite is poor. Immediately I start thinking about tumor, I start thinking about infection. So, just sort of, elaborating the importance of the history and just listening to the patient towards arriving at the correct diagnosis. So this is just sort of a picture illustrating the cycle of back pain, and just indicating that most of the time, conservative treatment is good enough to address back pain. I think what I like most about this image is that conservative treatment isn't only for when you have back pain. And in my opinion, I think conservative treatment is actually even more important when you don't have back pain, and the things that you do to prevent the back pain. I have a lot of friends that do CrossFit, and I kind of look at them and I tell them, like, hey, you're going to be, you're the one that's keeping me employed. When I bend over to pick up something from the floor, I'm not bending at the waist or at the back. Sometimes I'm bending, most of the times I'm bending at the knee. So essentially I'm saying all this to illustrate the importance of preventing the back pain in the first place. And some of the measures that you can do to prevent the back pain are some of these measures here in light blue. If you want to get into the literature a little bit on the most sort of effective ways to maintain back health, according to sort of peer-reviewed, rigorous sort of science, the most important things, and this is what I share with patients, is sort of aerobic exercises, good core strength, and just maintaining a good weight. Now, obviously there's some other things, but from scouring through the literature, those three things, you get, based on the 80-20 rule, you get the most bang for your buck with those three things. But then beyond that, even when you do all those things, sometimes back pain still happens, right? And when it does, ice, massage, medications, activity modification, physical therapy, chiropractic treatment, are all great options. And these are options that all my patients must exhaust before considering surgery, unless there are some red flags. And then once they do these things, most of them get better, but the ones that don't, then we have a conversation about doing some more invasive interventions. And that usually starts with injections for diagnostic and therapeutic purposes. And if injections fail, then at that point, we have a conversation about surgery. And it's all about shared decision making. It's all about informed decision making. I'm educating the patient. I oftentimes tell them that I'm the driver of I'm the passenger of the bus. They're the driver. I'm here to navigate them. I'm here to give them the information they need to make the best decision for themselves. And then that way, for the sort of rare situations where surgery is needed, then we sort of proceed into surgery. So when we start having the discussion about surgery, I think it's worthwhile understanding what the goals of surgery are, and it's really threefold. And I beyond three things, I have a hard time remembering, so I just try to keep things to three. So it's really threefold, the things that we can do, and one is decompression, and that's when we go in and we open up a space, make a space that is pathologically small or not patent enough, and making it wider. And here you can see a situation. Hey Ben, are you able to see my mouse?
I am.
Okay, perfect. Okay, so here you can see on this picture on the left, that's a patient with pretty significant spinal canal stenosis. And these are the facet joints here on the right side and on the left side. And this is the spinal canal. And you can see it's this sort of triangular shape. And you can see you can't see much cerebrospinal fluid in the spinal canal. Now, this patient has spinal canal stenosis, and this patient's probably presenting with neurogenic claudication, which most of you guys know, which most of you folks know what it is. I mean, it's pretty much patients who have a hard time walking long distances because as they extend up, that spinal canal closes further, and oftentimes they sort of need to bend forward or sit down. So this patient had neurogenic claudication that was recalcitrant to all conservative treatments, significantly impairing quality of life and activities of daily living. And the way you address it is you go in and you do a laminectomy. You can see here, 4 weeks post-op, the spinal canal is wide open and the nerves are no longer being compressed. All right, second reason why we do spine surgeries for stabilization. All right, and this is an illustration of a patient who has a spondylolisthesis at L4, L5. And spondylolisthesis is a translation of a vertebrae relative to the adjacent vertebrae. This is something that has been studied extensively and has been shown to have a strong association with back pain. Typically these patients present with startup back pain. Oftentimes they'll say, I have a hard time transitioning, going from laying down to sitting up to standing up. And when they stand up, they feel like they need to sort of gather themselves before they get moving. Oftentimes patients with spondylolisthesis present with that sort of complaint. With these patients, we'll do some dynamic x-rays to determine if there's any, dynamic instability. And if there is, then we have to stabilize them. That stabilization may also include a decompression. There's a lot of controversy currently about whether you need to stabilize spondylolisthesis. And the verdict is out for spondylolistheses that are not unstable. And what that means is spondylolisthesis that when they bend forward and backwards, there is not significant motion going on. However, in spondylolisthesis that are dynamically unstable, there's an unacceptably high revision rate when you just do a decompression without stabilizing. So in those patients, oftentimes they benefit from a stabilization, and that stabilization is usually a fusion with pedicle screws, rods, and sometimes a cage. All right. The last reason we do spine surgery is for deformity correction. And I mean, here you can see this is a patient who has scoliosis. And the reason why we would do this would be a couple of fold. In a patient with adolescent idiopathic scoliosis, if they have greater than a 50-degree curve before they reach puberty, the chances of them progressing over time is high, and the studies show that they will progress at about 1 degree per year. And if a patient who has 50 degrees of scoliosis progresses at about 1 degree a year, by the time they're 50, they'll have an 80 to 90 degree curve, at which point that's not, it makes it difficult to breathe, it makes it difficult to eat. And at that point, performing the surgery is extremely difficult. So in these patients, we would consider just doing the fusion and straightening their spine at the time where we know that their future outcome would be poor. So this is a patient with a situation like that, and the patient had their deformity corrected and stabilized, and did great. All right, so that's the reason why we do surgery, and those are the reasons we do. These are the goals for spine surgery. So how did things evolve over time from the point where we started realizing that, hey, if patients have these spine pathologies, they can benefit significantly from spine surgery? Well, initially, the way these surgeries were performed were via these shark bites, these significantly open, big incision, significant amount of soft tissue stripping types of surgery. And it's still the way most spine surgeries perform today. And the reason why, it makes sense. It's simple, it's economic, and it's familiar, and you see everything with your own eyes, and you're able to get the job effectively done. But over time, we've asked ourselves more and more, there has to be a better way to address these spinal pathologies with less collateral damage. And that's when sort of the discussion behind sort of less invasive spine surgery started coming together. So the downsides of the open spine surgery are the fact that it's associated with increased blood loss and increased transfusion rates, which is never good. Whenever you have to transfuse a patient, the outcome automatically goes down. These big open surgeries are associated with high infection rates, increased complication rates, and high reoperation rates. And actually, there's some studies that have shown that these muscles that you strip when you do these dissections, sometimes they just never become viable again. All right, and it causes more muscle atrophy. And remember earlier, I talked about one of the best ways to maintain adequate back health is by maintaining a strong core. Well, when you have paraspinal muscles that are pretty much denuded, then guess what? You're going to have back pain.
If I can interrupt you for a second too, I think that was something that years ago, before we started having these techniques that you're using, we would get the referral for PT, and they'd be post-op 6 weeks, and just the multifidi paraspinals are just gone. And they're like, you got to get those firing. And I was like, well, yeah, we got to get them firing. But so you can have like the neurological deficit as well as just complete atrophy. And then sometimes it just never really comes back to where you want it to be. So I think what you're going to talk about, I think, is going to be super important for the PTs and for the patients out there.
Absolutely. And it's kind of funny, if you want to get a little nerdy with it, we've looked at studies, and we've looked at the literature behind this, and we've done MRIs 2 years after open spine surgery. And this is not necessarily like a big shark bite like this. This is a 1-level fusion, and we do MRIs over time, at 6 months, at 1 year, at 2 years. And the amount of, the area of sort of paraspinal muscles that the patient has after an open spine surgery versus after a less invasive spine surgery staggeringly significantly different. Further sort of enunciating the point that you just made.
Right. No, and I love a good nerd out. So you're in good company here. But I think like the thing is too, if you don't have that atrophy, like you're saying, that the outcomes are going to be remarkably better, which then the patient's going to be much more satisfied too.
Exactly. And there's a lot more literature that's coming out that's going to substantiate this, because now we are measuring sort of the volume of the paraspinal muscle to determine frailty level. And what we're starting to find is that in patients who have a relatively lower volume of their paraspinal muscles, they typically don't do as well. So there is that association between the paraspinal muscle mass and outcomes as it relates to back pain. And those studies are coming out more and more over time. So, and just to illustrate a little bit more, the difference between doing sort of open surgeries versus less invasive surgeries. Here's a picture indicating, showing here on the left, the muscle stripping that goes on of the paraspinal muscles when you're doing open surgery versus sort of the muscle splitting approach where you're going in between the muscle fibers and performing the surgery that way. And you can imagine that, a lot of these muscles, they have sort of nerve interactions with sort of the periosteum over the bone and blood flow between the periosteum right above the bone. And you just disconnect all that. And scar just forms in that area, and these patients typically don't do that well. All right, so the tissue stripping approach is destructive. It's associated with increased pain, increased bleeding, infection, scarring, and chronic back pain, as we discussed. So then, this sort of led us to the notion of less invasive surgery. And I mean, it sort of makes sense, right? I mean, soft tissue sparing, significantly lower blood loss, lower surgery times, lower infection rates, decreased reoperation rates, decreased hospitalization, which is huge for me. I mean, I need to have a deeper meaning, for me, I'm always thinking of ways that we can reduce this, crazy healthcare spending that we have in the United States that isn't proportional to our outcomes. So decreasing hospital stay is a big contributor to that. And actually, most of the surgeries that I do in my practice, most of the patients go home the same day. These patients have quicker recovery, and there's a significant cost reduction and improvement in cosmesis associated with the less invasive surgeries. And here's just an illustration of your sort of old school, traditional, sort of maximally invasive open surgery versus sort of what we've evolved to now, where we're doing surgeries in a muscle splitting fashion, utilizing tubes and visual aids to address similar problems that we addressed with open surgeries.
Do you feel it's, we had that transition kind of arthroscopically, or, maybe just with the anterior approach for the hip? I know we're not here about a hip talk, but are you seeing, is the minimally invasive spine surgery, is it kind of just a few years behind where how the hip transition? Because you may used to be all the muscle splitting on the posterior hip, and then we realized that affected outcomes and time and money and hospitalization. Or do you feel like we're a couple of years behind in spine surgery?
Absolutely. Okay. Absolutely. It's certainly translatable, right? I mean, because, everything that we do in spine surgery, a lot of times we extrapolate from other sort of subspecialties, and a lot of the studies and a lot of the reason why this evolutions happen is because there are other subspecialties that are showing that patients do better when you sort of embark on a less invasive approach. Spine surgery is pretty delicate, right? And I mean, traditionally, you're like, look, I need to see all the nerves. We're talking about the spinal cord here. I don't want to paralyze a patient. So there is some hesitancy to moving towards making a surgery harder to do, right? Towards decreasing your field of view, and I put that quote on unquote because that's really not what happens with endoscopic surgery. What you'll find is that your field of view actually improves. So to answer your question, yes, a lot of the reason why this evolution's happened has been because of outcomes extrapolated from other subspecialties, laparoscopic surgery, arthroscopic knee, hip surgery, et cetera, et cetera. However, some of it is also due to the difficulty in being able to perform endoscopy in a muscular environment rather than in a sort of capsular environment. For example, with arthroscopic surgery, you go into the joint and it's like you're in a joint, you're there, you don't have to worry about any muscles creeping in or anything like that. But with spine surgery, that's not the case. There's a bunch of structures in your field of view. So working around that is much more difficult. And I think that was the hurdle that needed to be gotten over in order for us to appropriately evolve into endoscopic surgery of the spine.
Well, as you mentioned too, you're talking about life-altering mistakes there versus you can have some poor outcomes in a knee, but it's not, affecting bowel and bladder and ability to ambulate fully.
Exactly. Exactly.
That's,
Don't say that to the sports surgeons.
They're not on the call right now. So
all right, perfect. All right, we can talk about that. Yeah, so it's like you go in there, or I mean, this is in residency, we do arthroscopic knee surgery, and while we're going into the knee, oftentimes we'll ding the cartilage. It's like, oops, all right, keep going. I mean, you can't do that in the spine, right? I mean, if you ding the spinal cord, you might cause a patient to go from normal to a paraplegic. So yes, your point is well received. So evolution of spine surgery has sort of evolved from open spine surgery to sort of endoscopic spine surgery. And you can see this picture right here. This is a spine surgery performed through a 22 millimeter port, and the visualization is accomplished by a microscope, which you don't see on this picture. And then that's transitioned to sort of micro endoscopic surgery, which is typically performed in 12 to an 18 millimeter sort of port. And the difference between micro endoscopic and tubular surgery is sort of your visual aid. With tubular surgery, your visual aid is a microscope. With micro endoscopic surgery, there's a camera at the tip of the tube, okay? So your visual aid is pretty much a camera that's projecting an image onto a screen in front of you, okay? And then with endoscopy, it's much smaller. So I use an 8 millimeter port to perform my endoscopic surgeries. And again, kind of like micro endoscopic surgery, the visual aid is at the tip of the instrument, and that's projected on a screen in front of me. All right, so what is endoscopic spine surgery? Well, it's spine surgery essentially performed through a tiny incision, less than 1 centimeters, and in some cases less than 8 millimeters. It's performed with small tubular instruments and an endoscope for visualization. It's a concept that's been utilized in the past, but has not been refined until recently. And a lot of the refinement has been due to advances in optics and spinal image. And that's what's causing this sort of transition into the spine world lately. So why endoscopic surgery? Well, it's the most advanced state-of-the-art minimally invasive technique available. It's associated with minimal soft tissue trauma, which is vital towards a superior outcome. And it is the least invasive sort of method available at this time. And here's just some illustrations of the instruments that's utilized. And you can see this, I think this picture here is a pretty good picture. And the green circle is the camera. And the blue circles are sort of the spaces that the irrigation flows into the wound through. And then the working cannula is sort of the red circle, which is where you put instruments through to address different pathologies. And here are some different instruments that you can put through that working cannula to sort of remove bone. And here is a picture of the screen that we use for visualization. And it's a 4K screen, so it gives you a 3D impression of what you're seeing. And we end up getting a big screen, so go big or go home. So the endoscopic view, this is just sort of a slide to illustrate, what, the misconception that, when you're doing things through a smaller incision, you don't see as much. But this actually shows here on the left side, if you make an incision this big and you use a microscope, all you can see is this, all right? However, if you use an endoscope through an incision this big, because the camera is at the tip of the instrument and the camera is also angled and you can rotate it, I would sort of employ that you could actually see much more than what this field of view is indicating. I would say that you could even see all this and all this, because you can rotate the camera, because that camera is usually on a 30-degree angle. And when you rotate, you're actually seeing the sides rather than just sort of straight down. So this is, picture trying to illustrate a microscopic decompression. And you can see just the spinal cord that you've decompressed, but there's the traversing nerve root that's under the facet joint that you can't see. There's the contralateral traversing nerve root that is under the spinous process that you can't see. And there's part of the thecal sac cranially and caudally that you can see. Well, here's a similar situation, with a decompression, similar decompression, but with an endoscope. And you see here, you can see the dural sac, the thecal sac here. You can see the contralateral nerve root, okay, because you are under the spinous process, or you are just at the point of the spinous process. You can rotate your camera and have it face this way, and you can see the traversing nerve root on the contralateral side. And you can also see the traversing nerve root on the ipsilateral side. And if you rotate your camera appropriately, you can see much distal and much proximal to what you would have otherwise seen with the microscope. Hence the transition of big open surgeries to minimally invasive endoscopic surgeries. So what are the benefits of endoscopic spine surgery? Benefits include less pain, minimal bleeding, minimal to no risk of infection, shorter surgical time, minimal soft tissue destruction, minimal to no anesthesia. We do perform these sometimes without general anesthesia, which patients who are high risk will benefit from. One of the highest risks associated with general anesthesia is COPD. And I mean, we see a lot of patients who have significant pulmonary disease, and these patients, are suffering and otherwise will be unable to have their pathology addressed. But with endoscopic surgery, it allows us to be able to do the surgery with local anesthesia and some conscious sedation. And it's associated with quicker recovery and early return to all activities. I'm dabbling in an idea where I do endoscopic surgery and I tell the patient to just take 48 hours and take it easy and just go back to doing everything, just to see how it goes. So typically when we do our traditional surgeries, even MIS, as you all know, we restrict the patients. We tell them we don't want them lifting anything heavy. We don't want them doing any deep twisting, any deep bending. Who knows whether that helps or not. But I'm pushing the envelope, and what I'm finding, I've been doing these surgeries for about 2 years now, and what I'm finding is that these patients, I've had a couple of patients, run a marathon a few days after surgery, and they do just fine. I don't restrict them. I just have them go back to everything.
That's super exciting. I think that's one of the things that for therapists that we always feel, I think with traditional, open surgeries, that the handcuffs are kind of put on the rehab process for so long that they can actually be doing rehab and still be atrophying and not making as much progress as they probably could. But I understand like the risk reward sometimes is not there, but that's an exciting philosophical change for sure.
Right, and knock on wood, so far so good. I have not had one patient come back to see me with a fracture or recurrent disc herniation after endoscopy due to the fact that I had them return to all their activities within 48 hours after surgery. So obviously there are limitations. If a patient comes in with a scoliotic deformity like this, there's no amount of endoscopic surgery that will fix this. This needs to be addressed, in an open fashion. Next question is, who's a candidate? And patients that are candidates are typically patients who have the disc herniation. We're able to do a microdiscectomy through an endoscopy. We're able to sort of do a laminectomy and a foraminotomy, endoscopically treat sciatica due to a disc herniation or foraminal stenosis. Also able to treat spinal stenosis, patients who have significant spinal stenosis. We're able to treat that endoscopically as well. And this includes in the neck and in the low back and in the mid back. And then we're also able to do endoscopic surgery for spinal instability. We're now starting to perform fusions via an endoscopic approach, which is very interesting. And then, I recently did an endoscopic case, which I should have had some pictures, but I don't have any pictures, for a patient with a thoracic disc herniation. So these, I don't know if you guys know much about this, but a patient who has a thoracic disc herniation is one of the most complex problem to treat, because it's different in the thoracic spine versus the lumbar spine. In the thoracic spine, if you look at the nerve, if you look at the spinal cord the wrong way, the patient may go paralyzed. You just don't want to touch it, right? And the question is, how are you going to go all the way to the front of the disc in this patient, because you can't really move their spinal cord. In lumbar spine, you can move it pretty significantly, and the patients do fine. So usually the way you do this is you make these massive incisions, and you have to sort of do your exposure out to about halfway through the ribs, and you have to sort of come from posterior laterally to get to the disc. This is like a 7-hour surgery for a disc herniation. And then, and when you do that, you have to fuse that level. And then that sort of evolved to lateral surgeries in the thoracic spine. Lateral surgeries in the thoracic spine is a little harder because, the lungs are right there and patients have pneumothoraces, and sometimes you have to deflate the lungs. And you can't do anything above T4 because the scapula is in the way. And these are long 5-hour surgeries, and you have to fuse them. And I recently did a patient with a central disc herniation in the thoracic spine endoscopically. Took about an hour and a half, didn't have to fuse the patient, and patient felt great. I didn't touch the spinal cord. So, these are some pathologies that over time, endoscopic spine surgery will be the gold standard for. So conditions include spinal canal stenosis, like we said. You all know what that is. It's not having enough space in the spinal canal for the thecal sac, and that causes neurogenic claudication. Sciatica due to disc herniation, foraminal stenosis. I'm able to get an endoscope in from the sort of lateral, from the patient's sort of flank, and I'm able to sort of burr down some of this bone and burr down some of this bone and sort of open up the space for the nerve. It's important to have that conversation with the patient. It's important to discuss, regarding the risk and the benefits, and the benefits are immense, but there are some significant risks. And I always have this conversation with my patients. With endoscopy, there's a very high learning curve, and it's very highly specialized and has a steep learning curve. So, you don't want to do endoscopic spine surgery, or you don't want to have endoscopic spine surgery done on you for someone who's only done 10 of them. All right. I did 40 cases in the lab before I did my first one in a patient. And even today, after I've done over 100 of them, I'm still learning. So, and that's part of the reason why it hasn't been as heavily as adopted as you would imagine. It's just because the learning curve is just immense. Few spine surgeons perform these surgeries regularly enough to be proficient, and it's not suitable for certain cases. In the patient who has cancer, patient who has deformity correction. I need to modify this slide and take out fusion, because now we're doing endoscopic fusions. How is it performed? Usually under general or local anesthesia with conscious sedation. Skin is anesthetized with a block. Less than 1 centimeter incision is made, and we usually inject a tubular trocar in between the muscle fibers to create a potential space. And then depending on the pathology, the incision is either in the mid-back or in the flank. And next, the tiny camera is inserted through that trocar, which sort of keeps the soft tissue away, and the image is projected on the screen and guides the surgeon throughout the procedure. So I have a couple of videos here, and I think it works. And I'll just show you. This is a case that I did. This is a microdiscectomy, and it's a case that I did recently. And on average, it takes most surgeons about an hour and a half to get through a microdiscectomy, and I got through this in 20 minutes endoscopically. And excuse the music. So this is me going through the ligamentum flavum. And that's the epidural fat right there. And I don't have to take down any bone, 0 bone removal. And when this is done via an open incision, you have to take down a significant amount of bone, which is associated with bleeding and all other things. So I'm just using the scissors to sort of unroof the spinal canal by removing the ligamentum flavum or the yellow ligament.
Maybe you
And
could touch
here's
on this.
another-
Maybe you could touch on this too. I think for our patients that are watching, when you talk about not removing bone, I think kind of the importance is too for sports that have rotation, golf, tennis, even gardening. I think that just makes the healing process much, much faster. But you
Yeah.
maybe can clarify that. I don't know if you're seeing the differences on kind of rehab times.
Right, certainly. So a few things. Yes, it makes the recovery much faster. It decreases the risk of complication. It decreases the risk of instability. There is a notion of sort of your paraspinal muscles and the soft tissues in your back, including your bone, how they are the belts and suspenders that's keeping your spine stable. All right. Now you can imagine once you start removing those belts and suspenders through a big open incision, through significant soft tissue stripping, through significant bone removal, you put a patient at higher risk for instability. So, this is actually something that's interesting because for patients who have a spondylolisthesis, studies are starting to show that when if they have a spondylolisthesis, if you do an open laminectomy, the chances of them having a poor outcome is higher compared to an endoscopic laminectomy because you are minimizing the injury to the soft tissue envelope around the area. All right. So, and also, when you remove bone, you put patients at increased risk for fractures, pars fractures. And I've seen that happen, do a microdiscectomy. It's happened to one of my patients. You do a microdiscectomy open, you take out a significant amount of bone and they go back to play golf and they take a good twist. And next thing you know, they've broken through their pars interarticularis and now they have a pars fracture and now they need a fusion. So to your point, agreed with further clarification. All right, so this is sort of another video where I get a little closer. And I mean, you can see that the visibility is pretty amazing. Via the microscope, I would never have a view like this. I'm seeing everything before I cut it. That's the ligamentum flavum, and that's a thecal sac medial to it. So at this point, the case is done. I wasn't able to get any good pictures of me getting the disc out. So that's the traversing nerve root. And the way I know it's decompressed is because it's pulsating, and that's the disc space right here. And the disc that was there is removed. The patient had an extruded disc that came down here, and that's removed. All right, so the nerve is decompressed. All right, and here's the incision. All right, which is about half the width of my thumb, and I don't have a fat thumb, so my thumb's about like 1 centimeter. So that incision is about 6 millimeters, and I mean it's kind of funny because you do these surgeries, and oftentimes these patients see their primary care doctor, and their primary care doctor is like, "Are you sure they didn't perform sham surgery on you? Because I don't see an incision." The patient's like, "Well, I feel better." So it's kind of interesting where I've had a few primary care doctors call me and say, "Doc, did you really do surgery on this patient?" So it's kind of interesting.
Is this a psych consult?
Exactly. So outcomes of endoscopic surgery, good to excellent, given appropriate selection and adequate proficiency, and those caveats are key. It is as or more effective than traditional open and or MIS surgeries. Shorter surgery lengths, which leads to less anesthesia-related pathology, less soft tissue destruction, but it is not appropriate for all spinal conditions. All right, so that's it. I think you're muted, Ben. Again, thanks for having me, and open it up for questions.
Great. Oops, I'm just gonna stop the share here for a second.
I can stop it.
Oh yeah, if you want to stop the share, that'd be great. All right, so we got a couple of questions here. First of all, let's maybe go back in time a little bit and talk to us about your transition at the University of Texas and what helped you find medicine.
Sure, sure. While I was there, I was playing football. I was young and dumb, having a good time, and I was boisterous and rambunctious, and thought I was untouchable and unstoppable. And I got a bad injury to my knee, and I met an orthopedic surgeon. And due to my knee injury, I lost my scholarship, and ever since then there was no turning back.
That's great. That's how, like, we were talking offline beforehand, and it was that's how so many of our therapists have found PT as well. So here's a question too. Ergonomic or at-home strategies kind of from the work from home, kind of renaissance or changes that have occurred during COVID. Is there anything you recommend, maybe breaks or specific ergonomic aids or things like that?
Absolutely. I think sit-stand desks are fantastic. And I think, just go outside and move around. I think it's absolutely important. It's absolutely necessary. I'm actually finding that we're starting to see a little bit of an uptick in pathologies from people transitioning to working from home, because oftentimes they're just sitting at their desk and not really doing much. So my suggestion would be, wake up in the morning, get a workout in. All right. And sometimes maybe you can't do a 30-minute workout. Maybe do a 10-minute workout in the morning, maybe do a 10-minute workout in the afternoon. But certainly stand is an absolute must. And you just don't want to be sitting down for extended periods of time, because that will certainly lead to back pain.
Yeah, that's pretty much what we see in the clinic too. So I'll echo that for sure. As far as the trends you see in clinics that are successful with your patients, are there any commonalities when you see kind of better outcomes?
Yeah, well, it's kind of funny, right? Because we're all scientists, and there's a science behind everything that we do. But the soft skills I found have been the most valuable sort of adds to my patients, and I've seen that translate to sort of my patients that have gone to physical therapy. Oftentimes patients come to me and like, I met this doctor, he didn't even talk to me, he didn't even explain, he or she didn't even explain to me, what was going on. And you listen to them. And oftentimes that's just all that they want, listening, continuity of care. So something that I found that is typically associated with the good outcome beyond sort of the therapy that actually occurs is just, having a consistent person that's helping the patient and sort of being present with the patient during their sort of therapy modality. Something else that I like that I think is beneficial is aquatherapy. I think it's an environment where people are able to do activity in a sort of lower gravity environment with less sort of gravitational impact to their area of concern. But I would say sort of the soft skills, sort of continuity, and just sort of being present with the patient that's being cared for, and having a diverse sort of therapeutic modalities that the patient can benefit from in the facility.
One quick housekeeping kind of comment or question: what's the best way for people to reach you?
So what I will do is I will give you my email address, my cell phone number, and you can share it with the group.
Okay. And then maybe finally, what do you enjoy when you're not in the OR, when you're not in clinic, and you're not studying new techniques? What things do you enjoy?
So it's kind of hard, right? Because I have a 4-year-old and a 2-year-old.
So what did you used to enjoy?
There we go. That's a better question, because they're nuts. What I used to enjoy. So intramural sports. I do a lot of intramural, soccer. I like to get the competitive juices flowing, right? It's not just a run. And you get good exercise while you do that. Love to travel. Love to hike. Read. I play the piano. And something that's dear and near and dear to my heart that I miss is doing medical missions. So I started a medical mission while I was in med school to Nigeria, where I would go every year, and that evolved into a hospital that we built in Lagos, where we do surgeries, spine surgeries for fee, and then whatever fees we gain from that, we take that to the rural parts and do surgeries for free. So medical missions is something that I found to be very interesting and very gratifying and very humbling. And it sort of makes me appreciate ththings a little bit more. And sometimes I wish my patients here can interact with my patients back in Africa. It's a drastic difference.
Yeah, there's a privilege that, you know, by winning the birth lottery here in this country is evident. I think when you travel and you've done those medical missions, that's what you see. And I think that's actually a great segue too, just to let everybody know, for everyone that signed up for this, we are donating to the International Red Cross for Ukraine. So that's something we kind of do each month. So that was our charity for the month. But yeah, we love supporting those missions. So if there's information on that you have for us on your next one, let us know. We'll get that information pushed out there to our audience as well.
Will do.
But hey, I can't thank you enough. This was the first day we met. I'm blown away with our, kind of the conversation both beforehand, but also the presentation. I think the takeaway I had was that you're going to be a great listener for the patient. That's so much, like you said, that's so much of what our patients are kind of looking for, is someone who's going to actually take into consideration and not have their back turned to them typing on a computer. So I really appreciate that. And we look forward to, again, you're treating in Kirkland currently, and there'll be a transition to Bellevue at some point where you guys will presumably kind of grow a little bit, but we'd like to make sure we use you as a resource. So I'll have the information on how to contact Dr. Nwosu in the show notes, but also on the YouTube channel. And so you can kind of find it in any of our little areas there too. And a big shout out to Jordan too. She did a great job of organizing this for us from NeoSpine and kind of promoting it on your guys' side. So I appreciate that. But I really appreciate the time and great content, and exciting to see kind of where things are heading.
Right on. Hey, and I appreciate your time, and I appreciate everyone for attending. If you guys have any questions, I'm writing I just typed my cell phone number into the chat, and I will put my email address there now, so everyone has it. And if you want to reach out to me, you have any questions whatsoever, text or email works.
Great. Awesome.
Right.
Thanks so much, everybody. I appreciate it. Thanks, Dr. Nwosu.
All right. Bye-bye.
Have a good day.
You too.